Hi, my name is Elizabeth Edkin, and today I will be presenting a proposed community-based intervention for the control and prevention of type 2 diabetes among overweight and obese patients. Type 2 diabetes is a metabolic disease that causes the improper breakdown of sugars in the body. It is associated with health conditions such as hypertension and heart disease. The rapid progression of this disease can lead to internal body damage, stroke, and even premature death. As of 2007, diabetes was reported to be the seventh leading cause of death in the United States. However, this statistic is likely to be an underestimation since deaths related to the diabetes often cite cardiovascular disease, stroke, or other related conditions as the primary cause of death, with diabetes listed as a secondary cause. The prevalence of type 2 diabetes in the United States is high and continues to rise along with the obesity epidemic. While 8.3% of the total U.S. population is diagnosed as diabetic, an estimated 25% are likely to be in a pre-diabetic or diabetic state. The Centers for Disease Control predicts a 165% increase in diagnosed cases by the year 2050, and the disease is most common among adults that are over age 65. Type 2 diabetes carries some serious public health implications, including decreased quality of life, especially for the over 65 age group, an increased risk of mental health issues, premature death, and the related conditions mentioned previously. Economically, the medical expenses for people with diabetes are more than 2 times higher than for those without diabetes. This has severe ramifications on Medicare and Medicaid providers since incidence is much higher among that 65 plus age group. The total estimated cost for the disease in the US in 2007 was $174 billion. Type 2 diabetes is strongly correlated with genetic factors such as family history, beta cell and insulin genes, and obesity. If we focus on obesity, we see that adults who are obese, technically with a BMI of 40 or higher, reveal a 7.37 odds ratio for developing type 2 diabetes. This statistic gives us a 95% confidence interval of 6.39 to 8.5, so there's a very strong association documented there and throughout the literature. Another study looked at metabolically healthy obese adults, in other words, adults with higher BMIs but controlled glucose levels, to determine if metabolic health played a larger role in the development of type 2 diabetes than BMI, and they still found an increased risk, a relative risk of 4.03 for metabolically healthy obese adults compared to adults with body mass indexes within the normal range. You can also see that this risk ratio more than doubled if participants were obese and had poor glycemic control. As far as demographics are concerned, we mentioned that diabetes is far more prevalent among adults ages 65 and older. And when we look at race, the risk of developing type 2 diabetes nearly doubles for African Americans compared to their white counterparts. Relative risk has also been documented to be higher for Hispanic or Latino and Native American populations as well. The next risk factor we look at is poor diet. According to a review of the literature, diets that are heavy in sugar-sweetened beverages, fructose-containing items, and saturated fats are all associated with an increase in type 2 diabetes. I also found it interesting that individuals that are food insecure are more likely than food-secure individuals to exhibit diabetic symptoms. This study specifically mentioned a perceived absence of dietary recommendations as a possible cause for this disparity. A lack of nutritional knowledge revealed a 2.37 odds ratio in the development of type 2 diabetes, indicating that education and increased awareness of nutritional standards could be effective methods of intervention. The figure on this slide shows relative risk data with 95% confidence intervals for type 2 diabetes among adults that consume sugar-sweetened beverages, ranging from nearly no SSB consumption to more than one per day, which gives us a 1.83 relative risk statistic for that specific dietary behavior. Our final risk factor is physical inactivity. A multitude of studies cite the benefits of regular, moderate physical activity for decreasing one's risk of type 2 diabetes and even improving metabolic function. The image here is from the Men's Health Professionals follow-up study of over 50,000 men that shows us relative risk and confidence intervals for 3 different levels of physical activity per week. We can see that at least 150 minutes or more of moderate physical activity is associated with a 52% decrease in the risk of type 2 diabetes. Likewise, if we look at physical inactivity, a completely sedentary lifestyle has been associated with a 4.13 odds ratio for developing diabetes. Given the increasing risk of type 2 diabetes as body fat increases, healthy weight management interventions are an effective way to lessen the risk of type 2 diabetes among a given population. The National Diabetes Prevention Program has documented that modifiable risk factors, such as diet and exercise, account for approximately half the risk associated with the development of diabetes. And in addition, individuals with clinical signs of prediabetes, a 5 to 7% decrease in body weight has helped to delay and even prevent onset of the disease. The literature shows that developing healthy lifestyle habits is an effective treatment for diabetes that allows those diagnosed to regain control of their blood glucose and to even eliminate the need for medications. Given the high risk of overweight and obese individuals in developing diabetes and the effectiveness of lifestyle interventions in reducing their risk, I've decided to target individuals with a BMI of greater than 25 in a screening and counseling intervention. Based on the knowledge that only 1/3 of obese patients receive an obesity diagnosis or weight-related counseling from their physicians, this intervention would be delivered by healthcare providers throughout a given community. A study by Post et al. Found that when providers discuss weight loss with their patients, patients are more likely to attempt to lose weight. Therefore, objectives of this study would be to increase knowledge of healthy diet, physical activity, and other modifiable risk factors related to diabetes among the given population. We would also be looking to increase screening and healthy weight management counseling for patients receiving healthcare services with a BMI of over 25. And we would instruct patients on how to modify their behavior through prescribed diet and activity recommendations, either through email or in person. And we would hope to see that 5 to 7% decrease in patients' body weight over 1 year, which would inadvertently lower their risk of type 2 diabetes. As I mentioned, the study will take place throughout the community, and health providers will target overweight individuals. Because this study is a community-wide initiative, it would be necessary to bring together all of the health providers that would participate in order to train and refresh on proper healthy weight management counseling and to streamline the data collection process. Data to be collected would include BMI and A1C levels at the time of the screening, and patients would then elect to receive their counseling either electronically or face-to-face. Depending on the method of counseling, individuals would receive standardized education and behavior modification materials developed by the leaders of the study. I would anticipate that the electronic counseling could be more intensive than face-to-face counseling, which would likely rely on reimbursement to determine the number of sessions that would be covered by insurance. But ideally, patients would be followed up with for up to 5 years to determine if they're able to maintain their weight loss and or change their disease status. It is anticipated that an increase in the number of overweight and obese individuals that receive healthy weight management education and counseling will decrease their BMI and hence the risk of type 2 diabetes. If the sample populations can decrease their net body weight by the 5 to 7% that has been determined to prevent or delay the disease, we would expect to see up to a 50% decrease in cases of type 2 diabetes among those in the study. Finally, the study would carry a variety of strengths and limitations. Strengths would be a low cost and effective method for intervention, while limitations include multiple confounding factors, possible barriers to healthcare access, and challenges when it comes to the community collaboration that's needed in order to properly collect and manage data across multiple healthcare providers. Thank you for your time. I hope you enjoyed the presentation.